going to live in terms of a link. I will send you all this link, but it's going to live. I'm not sure if you guys are familiar with Nora's website, but a link to this is going to exist on Nora's website, Know About Pain. I'm presuming under this tab here, which is the media tab, but that's going to, that'll be dictated
Probably
by, yeah. Let's see here, get out of the way.
But you can find it through any.
Okay, let's get back to this one. Yeah, and I will send everybody the link on that. But here's the basic homepage, which is just going to give information on the next meeting, as you can see here for Katie's presentation today. It has the calendar, the monthly calendar, and when you click on the date of the meeting, it will obviously bring up the link for the Zoom, except for the Zoom connection, etc. This is very much a work in progress, just the beginning of it, actually. So there's nothing really of note in here. It's quite psilocybin laden, actually. So,
for those who weren't here, that was the last presentation. Right. Actually, we just all dropped acid and just kidding.
And over time, we're hoping that we'll be able to post many a recorded meeting on here. But for now, as you can see, Dan's last meeting is on here in terms of the Zoom meeting and the accompanying slides. The research which was forwarded to us from him also lives in here, obviously under the banner of psychedelic assisted therapy. And as you scroll down, there'll be additional subheadings for research associated with both presentations, but also that folks wish to share online and use this as a repository for. Likewise with resources, I mean, the obvious things that will be added in here with time will be the state toolkit, etc. So this is essentially for all of us to build out over time. So this repository is only going to be as good as what we all contribute to it in terms of what we'd like to see on there as useful tools. Specific cases as time goes on, there are some that pop up with presentations, but also we might be adding to that as individuals. And then finally, there's a Google Chat kind of forum that I've set up here that we can add new topics to periodically. The only one that's open right now is possible topics for presentation in the upcoming year. And so if we all participate via this chat group, we'll be able to probably more easily communicate topics that are desired or folks that have volunteered to present, etc. And possibly we could expand this into opening up a new topic of specific cases that people would like to discuss. It's really completely open for discussion in terms of what that will involve. And then the last thing just on there is the contact, which is just our dedicated Gmail account, which kind of goes to Nora and myself. And so, as I said, it's basically, this is just a framework. It's something that will build out over time and is very much dependent on everybody in the group to kind of bring forward useful resources that they'd like to share, not presentations, but research, and then participate as desired in the discussion group. There is one tab which I'd like to add up here, which is About, which was just kind of going to give the lowdown of maybe the history of the group and its purpose, etc. And if there's someone who'd like to step forward who's been involved in the group for a while and pen a little About tab and send it to me, that'd be fantastic. But that's the nuts and bolts of it.
So this is beautiful. Thank you so much for doing
that. No bother at all.
One of the things that I think we will find really useful is being able to use the research tab to put articles in that we can look at, putting things into the calendar if there's events that you want to share. I'm going to ask Paul to send emails out to remind folks to populate this. If you've done presentations over the last year, if you could send the content to Paul to post, that would be great. And for upcoming presentations, my preference is that we record them and then we can use this through a repository. Katie, I hope it's okay to record this today. Okay, great. So I don't want to cut in more into Katie's time. So I think what we should do, maybe in the next several sessions, Paul, you can give us another tour through there and show us what people have posted in the meantime. And
Absolutely.
please, let's get this really robustly used. I think there's a lot of articles that we read that we can share with each other, especially, and ideas. So great. So with that, without further ado, I'm going to hand it over to Katie O'Day to share some information about interoception and pain. And you should be able to share
Yeah,
the
hold
screen, I
on.
think.
I'm trying to make sure I can see my notes. And it keeps going into full screen. Let's see, notes. Oh, there they are. Okay. Okay, now I can share.
Perfect.
I just have too many windows open. Okay. Does it look full screen to you guys?
Yeah, yes.
Okay. So I can't see you all while I'm doing this. So Nora, feel free to keep an eye on everybody and to ask questions. If anybody wants to interrupt or has, I want this to be beneficial for you guys, however it works best for you. So I'm happy to answer questions along the way or at the end. This is a presentation that I recently did at the Occupational Therapy Association of Oregon. So I'm kind of just redoing it. I thought about editing it a little more specifically for pain, but I think, especially with how this group is so multidisciplinary, I think it's helpful to just kind of start at the beginning and give you guys a good understanding of interoception. I actually, as an occupational therapist, a lot of times we specialize in sensory processing, and so I've been working in the schools and in the clinics and just trying to work mostly with kids and helping their sensory processing. But then, I went to 2 conferences last summer. They were AOTA specialty conferences for both children and youth. And then I also went to one for mental health. And then I went to the Pain Summit in January, and just all of it's all ringing true for pain. And I have a family member who has complex regional pain syndrome too. So I think, I'm doing my own research for my family member to just figure out how to help them best. And it's all just cycling back around for helping kids and helping people with pain. So let's see. I think we're ready for the next slide. Okay, so the main thing I want you to take away from this course is interoception is key to telling us how our body is feeling, and then just to connect it to an emotion. So like this, you see my cute dogs, right? Maybe it makes you feel good because you have your own personal experiences with cute fluffy dogs. Or maybe it makes you feel a negative experience because you had a dog bite you when you were a child. We see things around the world and we connect them to an emotion automatically. And it also triggers our nervous system to give us feedback through interoception. I put the picture of the man cringing, and that's just a good example of when you can really kind of feel how somebody's kind of put yourself in somebody's perspective and think about how they're feeling and what is causing them to feel that way. The snake that might elicit some fear response, and the fires, I definitely know when the fires were in the Oregon area and creeping closer to the Portland metro area, my heart was pounding, and I kept telling people I was feeling like I was in fast forward mode, doing things like happened to be organizing my garage that weekend, and I was just going all over the place frantically when it was like, I don't need to be frantic right now. My nervous system is just making me feel funky. And also I wanted to share with you that when I did present this to the Occupational Therapy Association of Oregon, it was interesting because I did it on a Sunday morning, and afterwards I looked at my Fitbit. And interoception, that's our body signal. So that's our sense of hunger, pain, thirst, temperature, just all of our internal body signals. So it was interesting to look at my Fitbit data after I'd given this presentation and gotten ready for it. You know, I got up, got ready for my presentation. I don't give a lot of presentations to big OT, so I was kind of nervous. And looking at the data on my Fitbit, my heart rate was elevated to 120 beats at some point, but it was mostly like in the 80s, and normally it's like 60 is my resting heartbeat. So, you know, it was funny because Fitbit told me I was exercising this for 2.5 hours on Sunday morning, when really I was just giving a presentation standing up in my house. So I think that right there is just a big piece of the puzzle. I'm gonna go to the next slide. So I know you guys, especially if you work in pain, you know about the nervous system, and I'm not gonna, you know, belittle your knowledge, but you know, I just kind of want to remind us that the nervous system plays a big role in nearly every aspect of our health and well-being. It guides everyday activities like waking up, automatic activities like breathing, and complex processes like thinking, reading, remembering, and feeling emotions. Within the spinal tract, 80% of signals the body receives ascend to the brain, and only 20% of messages are descending the tract to control things like our motor skills. The nervous system controls brain growth and development, sensations, perceptions, thoughts and emotions, learning and memory, movement, balance, coordination, sleep, healing and rehabilitation, stress and the body's response to stress, aging, body temperature, breathing, heart rate, hunger, thirst, digestion, puberty, reproductive health, and fertility. And neuroscientists study these and other nervous systems functions in both healthy and disease states. So studying and interpreting the nervous system is really important because it affects human health and many areas of our overall well-being. One thing that I find really interesting is the studies. Interoception is really a booming study or a topic that people are studying in research, both psychological research and medical research. Back in like 2005, there were only about 50 studies that year that talked about interoception. But in the year 2015, there was over 350 studies out there talking about interoception. So this science is really getting big and big. And it's because they're able to look at like functional MRIs and see like deep inside of the brain what's happening. Just to go back to, you know, sensory processing, you know, we were all taught about our basic 5 senses in kindergarten or even earlier. And these senses are primarily like our external senses that we feel outside of our body. So we have seeing or vision, and vision integrates all the senses, especially vestibular and proprioceptive. Seeing orients us in our environment and helps us interact with the environment. It provides us with protective skills and be key to survival. Smelling or olfactory is linked directly to the limbic system for emotional connection and survival. Taste, gustatory, it's not about nutrition, it's like what tastes good and our reaction to what we taste. Hearing and auditory helps to locate where sound is coming from, screen out noises, and pay attention. So it's for communication, safety, integrates the body with the vestibular system. And like music, rhythm regulates our heart rate and respiration for calming, alerting, changing your mood. And then there's touch and tactile, which is the largest sensory system. So we have receptors all over our body receiving tons of input all the time. Our skin is our biggest organ. It's one of the first sensations to develop in utero, and we need it to be able to reach out and touch the world around us and to understand the world. We have to be able to tolerate touch, to learn and feel, and also to interact with others. We talk about deep touch versus light touch, Light touch can be both alarming or calming. Deep touch is typically grounding and calming unless it's hitting the painful threshold. And then next we're going to go into our internal senses. So these are like the three less commonly discussed senses, vestibular / movement receptors in our inner ears. When you move, it kicks in and it lets us know where we are in space and how your head is moving in relation to gravity. It's also a major organizer for all the systems, and the input lasts a really long time, like hours. And then there's the proprioceptive system. So body sense receptors and muscles and joints, and it lets us know where our body is and what our body is doing. Oftentimes our brain is hungry for input about what the body is doing in movement. And then interoception is more of our internal sense of our internal organs, like stomach, bladder, intestines, hearts, lungs. Interoception tells us when we're hungry, thirsty, if we have bladder or bowel needs. It tells us if we have a stomach ache, if we're tired. And interoception helps us to regulate the functions of the body and maintain homeostasis. So here's a good graphic that shows a ton of different sensations that we feel. So interoception allows us to feel the internal sensations coming from many areas of our body. The interoceptive system helps us feel, temperature, itch, sexual arousal, hunger, thirst, heart rate, breathing rates, muscle tension. It helps us sense a variety of general and localized feelings like warmth or coldness. So overall, like our sensory systems together work to protect us. They help us learn about the world around us, keep us safe and calm, regulate us, and they also help us attach and have social connections. So we also can talk about interoceptive awareness. So, that can broadly be described as the conscious perception of the internal body states. So like, for example, before a public speaking event like this, I feel an increased heart rate, muscle tense, stomach flutter, a slight overall shakiness. Interoception the interoceptive sense gives us like a huge mind-body connection. So it gives us the ability to notice these body signals, but then to connect the body signal to the emotion. So now here's the connection with our brain. The area of the brain that receives the most information regarding our interoception and interoceptive awareness is the insular cortex. And the insula uses the information sent through the nervous system from areas such as the heart, bladder, stomach, and translates the incoming signals into a message that we can identify on a conscious level. The insula was mentioned as early as like 1796 by a German physician, Johann Christian Riehl. However, most experts didn't think it had any major functions. No one paid much attention to that area of the brain. And due to its deep hidden location, it was just, people weren't really, it was very misunderstood. And it wasn't until modern advancing with brain imaging technology was developed that we are now able to look deeper into that area and study those deep structures. So the insula is emerging as like a crucial part of human behavior, and functional MRIs allow us to see like what areas are lighting up when we do these activities.
I have a question.
Yeah.
And maybe this is getting ahead, and maybe you're going to talk about this, but I'm interested in what you have to say about people who have a trauma history and maybe difficulty with interoception, and how you think that relates to some of this information about the brain. But maybe you're going to get to that too.
Yeah, that's actually really what I'm getting at. And I was thinking
Okay.
about kind of leaving that out, but then again, with it being 2020, I think that it's
Hugely important. Yeah,
going to be
definitely.
leading to a lot more referrals to you folks.
Yeah.
Well,
Right.
hopefully not, but who knows? So yeah, I just want to talk a little bit more about like the brain and body connection. And I mean, I have dogs, I don't have children, so I'm going to bring up a few studies that involve dogs historically, but I think that dogs also are a big key to that trauma piece, and we can see how dogs behave may be related to their traumatic history. I know when I was sitting in the presentation in Orlando, it was like a thunderstorm was going on as I was learning about interoception. And I was also thinking about my own dog who was attacked by a pit bull and had anxiety at baseline before that. And his whole reactions have changed. And now I'm needing to like reassure him all the time and get out my weighted blankets and things. So but a lot of it too is that my dog would, like, his stomach would growl and then he'd freak out and be all anxious. And I'm like, it's okay. It was just your stomach. Go eat some food. But yeah, so I was going to tell you about how Darwin actually, Darwin, the scientist, published an article or a book called The Expression of the Emotions in Man and Animals in 1872. And it's an exploration of the foundations of emotional life. And it's filled with like observations and anecdotes drawn from decades of inquiry, as well as his close to home stories of his children and household pets. And he starts by noting the physical organization common to all mammals, including human beings, like lungs, kidneys, brain, digestive organs, and sexual organs that sustain and continue life. He proclaims man and the higher animals also have instincts in common, all have the same senses, intuition, sensations, passions, affections, and emotions, and even the more complex ones like jealousy, suspicion, gratitude. Humans share some physical signs of emotion, like the hair on your back or neck will stand up when you're frightened. Or you might bare our teeth or grit our teeth when enraged. So that's just part of the evolutionary process. And Darwin proposed that mammalian emotions are fundamentally rooted in biology, and they are indispensable sources of motivation to initiate action. Let's see. So alexithymia is a term that's also in a lot of research studies, and that's broadly a term used to describe a problem with feeling emotions. So it's a Greek term used in Freudian psychodynamic theories, and it loosely translates to like no words for emotion. And it's estimated that 1 in 10 people have alexithymia, or pretty much poor interoceptive awareness. So alexithymia is pretty much people with impaired interoception. And look at all these diagnoses that it's related to. Poor interoceptive awareness is linked to eating disorders, anxiety, autism, attention deficit hyperactivity disorder, PTSD, panic disorders are really big. So dysfunction in interoception is increasingly recognized as an important component of different mental health conditions, including anxiety, mood disorders, addictive disorders, and somatic symptom disorders. In 2016, the Laureate Institute for Brain Research organized the first Interoception Summit, which was a gathering of interoception experts from around the world. And that conference or summit is actually on YouTube. I watched, I think, quite a few of those slides, and it is dry, but it's really good information. But it's, yeah, a lot of scientific research studies that are talking about how the heart rate, how, you know, it's just showing the different studies and talking about the interoceptive research studies.
May I ask a question about that?
Yeah, please.
What was I never heard of that. That's very interesting. A something where the lack of interoception. What was that word?
Yeah, interoceptive awareness, or alexithymia,
Okay.
I think is what you were asking.
Yeah. My apologies. I'm new to this. I'm physical therapy. One of your colleagues put me onto this. This is great so far.
Awesome.
Yeah. Can that be can that be promoted by the environment, or is it nature versus nurture? I mean, especially now with COVID times and high everything seems to be kind of out of control. Like, can that be promoted?
Yeah, actually, so I'll get into that, but
All right.
no worries. I appreciate you being here and asking questions. I kind of feel like I'm talking to a computer screen, so it's helpful to get that feedback from you guys too. But yeah, so I'm going to go into trauma a little bit and trauma-informed care, and
Okay.
then we'll get to how we can help people with this, because really it's a lot of the trauma and the ACE scores have showed that building resilience and using methods like mindfulness are evidence-based ways to help individuals with this. So yeah, like first, like what is trauma? It's basically a deeply distressing or disturbing experience. It can be abuse, neglect, household dysfunction, discrimination, community violence, medical stress, school problems, disasters, poverty, pandemics. And trauma-informed care is an approach that a lot of organizations are trying to implement more into their systems. And it's an approach that assumes that an individual is more likely than not to have a history of trauma. And trauma-informed care recognizes the presence of trauma symptoms and acknowledges the role trauma may play in an individual's life. So, you know, it's trying to change organizational culture to, I'm gonna close the door. Sorry, in case you didn't hear my dogs barking. Hopefully my boyfriend can get them to stop. So yeah, trauma-informed care is to kind of reduce the trauma at all levels and provide practice and awareness where, you know, we're assuming that people have had traumatic experiences in their life. And instead of asking like, what is wrong with this person, to like, what has happened to this person. And the intention of trauma-informed care is not to treat symptoms or issues related to sexual, physical, or emotional abuse or any other form of trauma, but rather to provide supportive services in a way that is accessible and appropriate to those who may have experienced trauma. And the goal is just to reduce triggering or exacerbating trauma symptoms or re-traumatizing individuals. So I'm sure a lot of you have heard of the ACE study that came out of Kaiser Permanente, and adverse childhood effects have been shown to affect our development and the reactions we have. And over 90% of people with mental health diagnoses have experienced trauma. 2/3 of children report one or more trauma by age 16. And I'm guessing this number is rapidly increasing in 2020. I mean, kids aren't even going to school. I think that right there is a trauma. And ACEs are common. About 61% of adults surveyed across 25 states reported that they had experienced at least one type of ACE. Nearly 1 in 6 reported that they had experienced 4 or more. And preventing ACEs could potentially reduce a large number of health conditions, For example, up to 1.9 million cases of heart disease and 21 million cases of depression could have potentially been avoided by preventing ACEs. And women and several ethnic racial minority groups were at a greater risk for experiencing 4 or more ACEs. And overall, like, ACEs are really costly. The economic and social costs to families, communities, and society totals hundreds of billions of dollars each year. So yeah, 2020 is the year of trauma. Yeah, 2020 couldn't be over sooner. So here's the other dog story. Another early giant who made major contributions to early psychology and trauma specifically was Ivan Pavlov. So yes, the bell ring was used as the trained conditioned stimuli that made dogs in his studies salivate in anticipation of the food. And losing such autonomic trained associations between the bell and food is known as extinction. And this is the cornerstone to like cognitive behavioral treatment, in which people are repeatedly exposed to signals that remind them of past traumas. What is less known is that in 1924, Pavlov made another huge discovery by accident. And that happened when there was a thaw in St. Petersburg during the spring, which caused the river Neva to flood his basement laboratory, inundating the cages of his experimental dogs who were trapped in the icy water with no way to escape. The dogs survived, but after the water receded, the dogs continued to be terrified, even though they were not physically injured. A significant portion broke down emotionally, behaviorally, and physiologically. So many of the dogs laid around motionless, barely paying attention to what was going on around them. Pavlov interpreted this as a sign of ongoing terror, which had obliterated any curiosity of their surroundings. So we now know that physical immobility and loss of curiosity are also typical of frightened, traumatized children and adults. And some of the dogs sat shaking in the corner of their cages, while others, previously tame, struck out viciously at their handlers. And those, again, are like behaviors that are well known today, seen in traumatized children. So we showed that after exposure to extreme stress, animals find a new internal equilibrium different from the previous organization of their internal housekeeping. And the dogs kept acting like they were in grave danger long after the event. When he measured their physiology, he found both markedly increased and depressed heart rates in response to minor stresses, which is signs of instability of the autonomic nervous system, as well as full-blown startle reactions in response to slight changes in their environment, like approaching lab assistants. So the intersection of trauma and interoception is the insula. And almost every brain imaging study of trauma patients finds abnormal activation of the insula. And this book, The Body Keeps the Score, is really good and kind of links in with what we're talking about too. So, it's like, how do we know we're alive? In 2004, Ruth Lanius posed a new question, like, what happens in the brains of trauma survivors when they are not thinking about their past? And her studies on the default state network, DSN, opened up a whole new chapter in understanding how trauma affects self-awareness, specifically sensory self-awareness. So 16 normal Canadians were recruited to and lied in a brain scanner, instructed to think about nothing in particular. She then asked them to focus on their breathing and to try to empty their mind as much as possible, and then repeated the experiment with 18 people with a history of severe chronic childhood abuse. In the normal subjects, she saw activation of the DSN regions, and van der Kolk in his book explains this area as the Mohawk of self-awareness. And it's the midline structures of the brain starting right above our eyes, running through the center of the brain all the way back. And all of these structures are involved in the sense of self. And the largest area is the posterior cingulate, which gives us a physical sense of where we are, like our internal GPS. And it's strongly connected to the medial prefrontal cortex, which is like a watchtower. It makes judgments and perceptions of our senses, and it helps us differentiate if the smoke you smell is danger and you need to flee, or if it's the food you're cooking. So the insula is connected to this, relaying information from the viscera to emotional centers. And the parietal lobe integrates sensory input. And then the anterior cingulate coordinates emotions and thinking. And all of those contribute to consciousness. So the contrast in the scans of the 18 chronic PTSD patients with severe life trauma was startling. There was almost no activation of the self-sensing areas of the brain. The only area that lit up in their brains was the posterior cingulate, the area responsible for basic orientation. So the conclusion that the scientists made in response to the trauma itself and coping with the dread that persisted long afterward, after the patients had learned to shut down the brain areas that transmit the visceral feelings and emotions that accompany and define terror. Yet in everyday life, those areas are responsible for registering the entire range of emotions and sensations that form the foundation of our self-awareness, our sense of who we are. So tragic adaptation had occurred in an effort to shut off the terrifying sensations that also deadened their capacity to like fully feel alive. So the disappearance of the medial prefrontal cortex activation could explain why so many traumatized people lose their sense of purpose and direction. So overall, the better the insula, the better your interoceptive awareness. And it's also tied into sensory modulation. So interoceptive awareness is like a sliding scale for various body parts. For example, you might have low registration for a sense like hunger and high registration for pain. Low registration for hunger may be adding to the obesity rates. We eat because it makes us feel good. And if we don't register that we are not hungry, we may continue to eat throughout the days as a coping mechanism. I know I was gonna try to do Whole30 right before the fires hit, and I changed my mind. Nope, I think I'll keep eating some chocolate right now to make me feel better, but you've got to be aware of it. So, body signals that are too big, that's related to sensory modulation disorder, being over responsive. So strong, overpowering, too many body signals noticed all at once, or body signals maybe too small, and that can be sensory modulation disorder, like under-responsive. So the muted, we don't notice the body signals until they're really intense, or body signals may go completely unnoticed. This may be the people who, are walking around with a broken leg and they were just fine, but this might be because they're kind of under-responsive. But then again, body signals can also be distorted, and that's related to sensory discrimination disorder. So the body signals are noticeable, but we don't have that clear enough an idea to give us the specific detail about the location or the type of feeling. So this slide goes into how really us developing interoception is a developmental process. And it's really, the insula is connected to attachment, and individuals who have experienced poor attachment with their mother or caregivers at birth also have poor interoceptive awareness. So this is a cyclical example, like the baby has a need. So the baby cries. The baby doesn't know what the need is yet. They're just a baby. But the mom usually figures it out. They you know, are they hungry? Are they wet? Are they tired? Are they uncomfortable? And then once the needs are met by the caregiver, the baby can trust, and it's a cyclical cycle. So the baby then has a need and the baby cries and the needs are met by the caregiver. So the caregiver is being the insula for the baby as they're developing their own insula and interoceptive awareness. So like coming back to the intersection of trauma and interoception is interoceptive awareness. So veterans with PTSD are actually, there have been studies that they are unable to identify their heart rate as well as a normal person who does not have PTSD. Even if, you know, they're trying to feel their heartbeat with their fingers or feeling it with on their, you know, different ways around our body, they have a really difficult time identifying and counting accurately with their heart rate. And that goes back to, you know, they, on the front lines, they were really probably having to suppress their emotion, their sensations, and weren't, you know, able to connect the emotion of being in a panicked state when somebody's fighting against you. They just have to keep working and keep doing what they can to protect whatever they're fighting for. So it's also, you know, people with anxiety have a hyper ANS response, including hyperventilation with like an interoceptive threat. We can go to the next slide. So when the interoception system is properly working, the sensations alert us that our internal balance is off and motivates us to take action to do something that will restore balance and help us feel more comfortable. For example, if we feel cold, we automatically connect that to needing to get a sweater. If we feel anxious, we seek comfort. So with this slide too, I want to connect that both our homeostatic or physiological emotions are also considered emotions, a similar way that the affective emotions are. So we feel sensations, then we notice the body state or emotion that we're in. We are urged then to act. We do the action, and then there's an outcome, like hopefully it's feeling more comfortable. And typically each emotion feels differently in the body. So like before speaking in public, your heart may race, your muscles may feel tense and shaky, breathing may be shallow, stomach may feel like butterflies. An example of when interoception awareness is not working so well is a quote here: "If an adult does not remind her, my teenage daughter will go an entire school day without eating a single bite of food or drinking a single drop of liquid." Another one is, "Our 10-year-old son had tantrums 4 to 5 times a day at minimum. He was angry and defiant. We began feeding him every 2 hours and giving him an 8-ounce cup of water. And we were stunned to realize one Sunday that we had gone an entire day without him having a single tantrum. And that was the first day I felt some peace was possible in our home." Or, "I do not realize that I'm getting angry until I'm exploding with anger. By then it's too late. The feelings are overwhelming. I have little control." Or, "I would only realize I was really angry after I hit or kicked something." Or, "I feel so many things inside my body at once. It's messy and chaotic. I can't make sense of it all." I can feel a negative emotion, but I'm not able to connect to identify which ones and why it's happening. And this is a really good one. "My son has been taught every single coping skill known to man. Take deep breaths, go for a walk, ask for help, but he doesn't feel the need to use these strategies in the moment. His school labels him as a major behavior problem, and sees him as oppositional because he won't use the coping strategies they've taught him.
Hey, Katie.
Yep.
I think you're doing awesome. And my wife is over here kind of like grunting and awing at what you're sharing. So you even have like passive people also listening, I'm sure. Like Paul probably has some people in the background there too. What I was really enjoying about that is connecting my understanding of proprioception to that. So like I talk about and think about proprioception all the time as a physical therapist. It's like, you know, cerebellar response and subconscious movement control. And I'm really enjoying thinking about this in parallel with the subconscious, right? So you keep on speaking of they're not aware of or they're not able to manage.
Mm-hmm.
And it just goes to show like how much that physiology just impacts us before we're even consciously managing it. And tying that with proprioception is helping me better understand like clinically how that might be relevant. So you're doing awesome. Keep it up.
Thank you. I really appreciate the feedback. And yeah, I think that now moving forward, I can give you guys some more strategies on how to help people. And I think the biggest thing is we need to teach people about their body and how their body works and the physiology of their body, and teaching them about interoception, because really that is what pain is. Pain is our, you know, we feel it, and our pain might be different than how somebody else feels it. And you know I have the family member I was telling you about, and they're always rating their pain at like a level 7, but they're talking, walking, not crying. And I'm like, doesn't look like a 7 to me, but I'm not that person with that subjective pain rating. And I know you guys understand this well too, that it's good to get that kind of data to be able to compare and contrast, but it's hard for everybody to have the same sensation and reaction.
Well, and this is Nora. I think too that what's so interesting about this idea, and some of us were at Betsy's presentation about polyvagal theory, which is very much overlapping with all of this. And
Yeah.
they talk about the idea of the social neural platform and being able to be in that level of homeostasis to be able to do the kinds of self-care and social engagement that you need. And people who live with pain, a great deal of them, we know from ACEs and we know from our clinical experience, have probably trauma history. And I think that this explains so much of why it's so hard for folks that we see to listen to their body and to be willing to tolerate understanding what their own body is teaching them, and how we get into this frustrating process of feeling like they're not kind of getting it. And so this whole realm of knowledge kind of allows me to appreciate so much more the need to scale way down to helping people create a sense of safety inside their own body. And that it's probably an arena that is relevant way beyond the pain world to kind of many clients. So, you know, when you talk about an organization becoming trauma informed, I think the idea of helping our colleagues understand that need to establish a felt sense and a sense of safety is probably really important to people feeling like they can receive information and input from healthcare practitioners, period.
Yeah, and I think that this is really ringing true with the specific family member I'm talking about. You know, that person has a history of ADHD and is a young individual. And that person actually recently had a cardiac event and was dead, and then was brought back to life through CPR, and then ended up in the ICU. And I was bringing this topic up to the doctors and staff in the ICU as they were going through ICU delirium, which they happen to have. And it's apparently after you have a myocardial infarction, they are putting a cryogenic catheter in as kind of a typical way to prevent any further tissue damage. And I read a study after I was figuring this out with my relative that 100% of people who are put under the cryogenic therapy they go through ICU delirium. And so here I was being this family member and thinking about interoception and talking to the nurses and doctors about it. And with ICU delirium, that person was also like, you know, sensing the world around them and hearing things and putting things in perspective in their own brain. Like, yeah, the nurses and doctors are CIA agents out to get them. And the person would wake up in this like rage-like state where, you know, it's like where the code gray people come down to the ICU because the person's like getting in a rage state. And I think a lot of this is all connected to our insula and our interoception as well. And it was interesting when I brought it up to the whole rounds team that came up. A few of the people that like acknowledged me and really like looked at me and like nodded their heads up and down were actually some of the younger doctors and pharmacists or who knows what. And I think that maybe they're learning more about it in school now and because of all these research studies that are coming up, but not everybody knows what I'm talking about. And I think the biggest thing coming out of this is there are really, it makes a lot of sense and it's evidence-based and there's a lot of easy ways to work on this. So first, like we need to teach our clients about our senses and the body, and this can look different depending on their age and cognitive ability. Like for the young kids I'm working with in the school district, I'm teaching them about their bodies and how the body works. There's one of the presentations I saw was at the AOTA conference was by Kelly Mahler, and she is an occupational therapist who really has dug deep into interoception, and she's created what is called the interoception curriculum. And in that curriculum, she breaks it down into 3 sections. So in the first section, you're teaching the clients about their body parts in a sequential manner. So first you teach about the hands and how the hands can feel tingly, they can feel hot, they can feel cold, they can feel wet. And doing like little experiments, like I'm gonna squeeze my fist tight, tight, tight for 10 seconds. Oh, how do your hands feel? Ooh, my hands feel tight. They feel still. And so there's a lot of like what she calls focus area experiments that you can do with clients. And I think a lot of this could be really applicable in pain science too, and pain therapy. I have a paraeducator that I work with, and actually a child who has autism, you know, not blaming the child, but he threw a chair at her and the chair leg went into her calf and it created this huge hematoma, which she didn't go to the doctor. She didn't go to the ER emergently because she didn't really feel like that pain. I think she has a high pain tolerance herself, but the doctors at the hospital said, if you hadn't come here within the next 2 hours, we would have had to amputate your leg. So she was going to a physical therapist for pain. And the next body part after hands are feet. So she's teaching the kids about how their feet can feel stiff, they can feel sweaty, they can feel curled, and all these different sensations. And she brought that to her physical therapist, and the physical therapist that she was like, where did you get this? So I think that there are things, especially within the curriculum, that can be helpful. And I'm not linked in with Kelly Mahler. She's a pro. I'm just, she's not giving me any money or any encouragement to tell you to go buy her products or her books or anything, but I'm just trying to get it out to as many people as possible because 2020 is a traumatic world. And I think a lot of people are going to benefit from this, both through pain science and from I mean, kids are going to go back to the schools and they're not going to be regulated. So I think this could be a really great way to help work on having the kids be more regulated. So this is just a slide talking about, like, yeah, like I said, we have the emotions, and both affective emotions and homeostatic emotions are considered emotions. So then here's more of our homeostatic ones, or physiological. So self-regulation in general is just the ability to identify and manage the way we feel. And homeostasis, you know, what is it? It's the ongoing process that maintains our health, comfort, and well-being in our body. So changes in the tissues of our body alert the brain via our interoceptive system. And consciously, we feel a sensation and are behaviorally motivated to regain that internal balance. So this is self-regulation, and that involves pain too. So, and unconsciously, automatic messages are sent from our brain to regulate our body. So together, the conscious and unconscious are similar to an iceberg, where 80% is unconscious and only 20% is conscious, or things that we can observe and feel, like our heartbeat. So a good way to think about it is body, emotion, action. So the body senses heavy eyes, slow muscles, unfocused brain, and we connect it to, oh, that means tired. And then, you know, we can do an action to get us untired. Drink coffee, have some cold water, take a shower, take a walk, self-talk. But you have to know exactly how you're feeling in order to manage it effectively. So noticing the sensation is the first step in noticing how the body is doing, and then we connect the sensation to an emotion. So both noticing the emotion and connecting it together is that interoceptive awareness. We then have to have the urge to act if we choose appropriately, and which will then help us feel regulated. And hopefully that outcome is that the discomfort or pain would fade. So yeah, the top two green ones, like notice the sensations, faster heart, clenched fists, tight muscles, louder voice. And then we would connect that to the sensation of meaning angry. So then we have the urge to act, and we regulate with an action, like go for a walk. And then the outcome is that the discomfort fades. No more faster heartbeat, clenched fists, tight muscles, loud voice. I think I'm missing up a few things, mixing up two ideas here, because I think I've got angry, but then I've got dry mouth, dry throat, thirst, drink. So I think that's a little messed up there, but that's just a different idea. Like if your mouth is dry and your throat is dry, you connect that with, oh, I'm thirsty, I need to drink. So then this is just a slide that I had on about pain. So I think addressing interoception is essential when helping clients manage pain, and teaching clients about interoception is a good start. So teaching them about their body parts and about how that is connected through the insula and it's connected to our emotions. So every body part has a different ways it can feel. And there's different, like with Kelly Mahler's curriculum, she has each body part. She starts first with her hands, then her feet, then her mouth, ears, and eyes, kind of like the more obvious body parts that kids and people with various cognitive abilities can understand. And then after she does more of the external body parts, she moves towards having us teach them about how our internal organs can feel. So, you know, get out the pulse oximeter if you're working on breathing and how your lungs can feel. Get out the heart rate tool too for measuring their heart rate when you're teaching them about how your heart can feel pounding or still. And then, yeah, there's different, she has different words for how all the different body parts can feel. And I can share that too a little bit in the resources on the website. I have put together a group of articles that discuss interoception and pain, so I can add those to the website or get them to Nora and whoever was Paul or whoever was managing it, so you guys can read more. But the one article that's really interesting is called Ghosts in the Machine, and it's an article that proposes the concept of residual interoceptive images, and it connects it to like a multi-level nature of chronic pain perceptions. Yeah, it goes.
Can you say more about that?
Yeah. So lastly, we introduce a treatment concept forged upon the possibility to modify the interoceptive chronic representation of pain through external input in a process that we call interoceptive modeling, with the ultimate goal of reducing pain in chronic subjects. I haven't read it in a month or so, but yeah, it's pretty interesting talking about like the visual images that people have in relation to pain and the perceptions that we feel about it. So these are some ways we can think about how we already are connecting emotions with pain, like the Wong-Baker pain scale is using those emojis to connect us with how we feel within the pain scale. And the zones of regulation is a really commonly used curriculum in the schools, where we're having kids label themselves as, I'm happy, so I'm in the green zone. I'm tired, so I'm in the blue zone. I'm angry, so I'm in the red zone. And that is a really prevalent curriculum used. But really the problem is how can we expect kids to understand their state of emotion of being happy or tired or sad because we're already assuming they have good insula and good awareness of that. And oftentimes we should start with the interoception curriculum as a precursor to that, to help the kids learn like, oh, my hands can feel sweaty, wet, cold, dry, tired, you know, and then they connect it to the emotion of being like, my hands. Oh, and one thing that they do too is like a body check-in chart. So you show them a picture of the body, and as you progressively add more body parts, you would do a body check chart. And I think that this could be really helpful for people with fibromyalgia too, because like you could say, have them identify how their hands feel, how their feet feel, how their eyes feel, how their mouth feels, and then teach them how to connect that to an emotion. Like there was one boy we were doing it with last year in the schools, and he was coming in from recess, and the para was doing a check-in with him to see how he's feeling throughout the day. They were doing this, and he came in and he's like, Teacher Sarah, I already know what you're gonna say. My feet are sweaty, my hands are cold, and I'm out of breath, but I'm in the green zone. I'm good, I'm happy, I'm ready to learn. And so he was already connecting it to the zones of regulation when we were kind of backtracking. And I felt like that was pretty awesome for this third grader in an autism classroom. But yeah, moving on, like mindfulness is like the evidence-based treatment. So going back to, yeah, even learning about your body is mindfulness, because mindfulness is the quality or state of being conscious or aware of something. So teaching interoception is inherently a mindfulness strategy. And it's a mental state achieved by focusing one's awareness on the present moment while calmly acknowledging and accepting one's feelings, thoughts, and body sensations used in a therapeutic technique. And mindfulness is based in evidence and will help our clients be more connected to themselves and build better interoceptive awareness. so everyone can benefit from mindfulness strategies.
Can I ask you a question again?
Yeah, I think I'm wrapping up with what I was going to say. This really quickly, though, before you say your thing, this movie is on Netflix. And I think it's really interesting to just go back and think about human development and watch babies and thinking about like how they're developing that internal awareness. But yeah, let's open it up to questions because I know we're running low on time.
Yeah, wonderful. Thank you, Katie. That was fantastic. Thank you so much for that really well put together talk. We're going to formally go till 8:30 because that's the time that we have blocked out. I just want to acknowledge that. But I think if people want to stay beyond that and talk and pick Katie's brain or, share ideas, I think that's totally fine with me. And I imagine it's fine with Katie. So, but if you need to go at 8:30, you have a hall pass. So yeah, go ahead.
This is the best Zoom meeting of my life, minus the dating one that I did earlier today. How does this? We had a patient today, Christy. That would this apply to a peripheral nerve injury at all? Could you use this for maybe even diabetic neuropathy, something like that? Spinal cord. I know it's not really peripheral, but could you apply this at all to this, or is it specifically brain CNS type stuff?
Good question. I mean, I'm not a practicing pain specialist, but I think it makes sense that it would. Let anybody else want to answer that question?
Well, I mean, interoception is a central nervous system function, but every peripheral nerve is attached to the central nervous system. So it kind of depends to me on what it is that you see in the patient.
Yeah.
If they are not feeling comfortable kind of moving in their body, if they have that sort of sense of disconnection from their own ability to move fluidly and easily, like say, this happens all the time with complex regional pain syndrome. People kind of forget that they have the rest of their body. And so that compounds the problem of what's happening with the CRPS limb, right? And that only exacerbates the lack of interoception, the lack of a sense of safety, the lack of healthy movement of the sympathetic ganglionic chain, the ability to regulate breathing. So that all is going to be in service of diminishing pain because you're creating greater homeostasis overall. That's what I would say.
I think it might influence the homunculus because sometimes that could be smudged during the peripheral injuries.
Sure. Mm-hmm.
You think in that like a top-down approach? Okay.
For sure.
Thank you.
Yeah.
Yeah, thanks.
And that's always helpful.
Yeah, on that point, like another way to improve disambiguation or greater tactile differentiation is through the same strategies that Katie's teaching us today, which is just that like kind of subjective intentional awareness practice of basically determining what it is we're feeling and what the quality of that experience is like. Great talk, by the way, Katie. Really enjoyed it.
Thank you. Does anybody have any other questions? I mean, I'm just becoming like an interoception nerd and trying to get this out to whoever might be applicable to. So if you guys have any...
One question I had, I mean, I think you kind of implied it along the way, and this is such a holistic practice. I mean, anything we're doing where we're causing our clients to like pay better attention to the experience they're having is really playing with interoception in one way or another. But one question or comment I maybe had was you'd implied a little bit that the experience of trauma, it's kind of ubiquitous. It's kind of like all in the interpretation because it's just the way we develop our strategies for kind of dealing with the intensity of the experience we're having. And so do you practices are effective at a kind of a broader population than just the kids that like come formally. You find that like this is sometimes like useful in what would otherwise be a non-pathological client?
Yeah, I really think it really can play a big role for people. I mean, even the family member I've talking about didn't really experience a traumatic upbringing, but then again, they've had experiences in their life that could be considered trauma, like a surgery or something. So, it's like, who knows what's going on with people and their history. And I think we should just use this as a good starting point to just make sure that they have a good awareness of their body parts and functions and how it relates, and just kind of acknowledge that they've experienced trauma, even if they haven't.
Yeah, I mean, it comes down to the definition of trauma, I guess, when we look at that. And by some metrics, like just being born is a fairly traumatic experience. I mean, it's all the skill set that you're able to kind of utilize to determine your fragility or otherwise to a large degree.
Yeah, and building upon that ACEs study, they're talking about how resiliency and providing a calm, stable environment is really huge, and people not having the trauma really affect their lives in the future. So I think just trying to keep building upon resiliency and forgiving people when, they make little mistakes or whatnot.
Yeah, I think that's interesting. I mean, the more effective these kind of strategies that you're teaching are, or the more effectively they're employed, it doesn't actually make the history or the narrative disappear, but it does like basically change the dynamic of the relationship between the individual and their narrative, right? And it doesn't make the experience that they had different. It just means that the person that's experiencing that narrative now in the present isn't re-traumatized by it, or isn't triggered by it, or it's not problematized even to have that narrative kind of experienced again.
I think that's a really good point. It's interesting to listen to you talk about this, because I started out my career as a trauma therapist for little kids. And with little kids, of course, you can't do talk therapy. They just can't sit still for it. They don't have the cognitive capacity to process abstract ideas. They don't even really get the Lion King and how Scar, manipulated Simba, right, and killed his father. They up until about 9, they don't really understand that. They don't have the capacity to understand that. When I shifted to working with adults, my big mistake was shifting to a talk therapy model, and it was really ineffective. So this doing thing, it's so interesting to hear you talk about helping people come back and connect with their bodies. And I think it gets back to your point, and I'm sorry, your name doesn't pop up, but reframing those events not as things that leave you broken and unable to protect yourself, and unlike the rest of the world, lacking in self-efficacy, but saying, oh, yes, bad things can happen, and I can tell in my body when something isn't right, and then I can do something about it. So it's so fascinating, Katie, to hear you talk about this and see how it fits in I'm a mental health therapist, you can probably tell, and how it fits with that.
Yeah, and honestly, I brought this up to a lot of the school psychologists and social workers and counselors in the school district, and they're just like jumping for more information, because yeah, what can you do with kids? It's best to do things with them and name it.
But the things that you suggested are really powerful ones. Connecting with your body, doing things with your body, noticing that, those are really powerful.
Yeah, something that I think Katie and Nora both brought up is really critical here, which is kind of creating an environment where someone can recognize their own experience and not feel threatened by it, right? It's like we're so easily overwhelmed by the intensity of experience itself. Like that's like even in meditation, like we have a tendency to be overwhelmed by the intensity of it, and that feeling that you're safe to kind of develop strategies for being curious about it. And like Katie, like you were saying, you know, what do your hands feel like, right? Like, what does it feel like to be embodied? And then kind of, I think particularly with children, kind of putting labels on it or putting descriptions on it can be really, really effective. And as we age, like I think we tend to go more toward the description or the label, and that we're much better off trying to stay at the immediacy of the sensory experience itself, or kind of the energy as it appears. But the labeling, I think you're really right. It's not something I really recognized before I had children. And that oftentimes, like, there's a resistance to kind of even feeling what their embodied experience is like. There's like a contraction, and you can just see it happen in real time. It's fairly off-putting. But you can see it happen in like real time, where they kind of contract around their experience and then have like resistance outward, and they're functionally disembodied at that point, you know. And we're talking about the trauma of I don't know, getting the wrong thing at the grocery store, right? I mean, it's like yeah.
Yeah, so that's where I'm like trying to remind teachers that kids aren't intentionally trying to be naughty. They're just reacting in the moment in what's going on, and they can't stop kicking and fighting if that's, you know, what state of mind they're in. And honestly, I've connected with my dad a little bit about this, and he's not a very emotional person. Like, he doesn't give me a lot of hugs or tell me he loves me and things. And I know he does, so I haven't worried about it. But I think I've realized that he grew up in a large Catholic family where there was 8 children, and he was the 6th child. And so, you know, he had a lot of connections with his siblings, but he didn't have that really good attachment with his mom, because she was working as a teacher and she was trying to care for her whole house of 8 children. And grandpa was working all the time too. So I think that connection just wasn't firmed up as my dad was a child with his own parents. So then he just didn't necessarily do it very well for us. And I just have to accept that, yeah, I know my dad loves me. I know he was also a Vietnam vet, so I think that might play into it too. But I think you're kind of speaking my language.
I think too that patients, when they come into physical therapy, who have a poor sense of interoception, a poor sense of felt sense, who don't know how, you give them a home exercise program and they can't figure it out, right? And we think of it as the simplest thing in the world. And then they feel a sense of shame, like they failed. I mean, I think that there's some anxiety just in the performance of the home program, and we blow right past that and like get mad at them that they were not, you know, that they aren't complying with their home exercise program. You know, I forgot it, I didn't do it, you know, what's underlying some of that. And I was reading some polyvagal theory. It was this really awesome physical therapist. I will try to send the link to this video because it was a fantastic presentation about the role of mindfulness and yoga in relationship to polyvagal theory. It's brilliant. And she talks about the way that the dorsal nerve, the dorsal vagus nerve responds to changing heart rate variability through changing breath, and that the exhale, as you would suspect, lowers heart rate, and the inhale raises heart rate. So just playing with the exhale as you teach exercises is going to help people be able to engage on that social neural platform so that they can respond to your visual cues and see you smiling at them and feel safe, right? And if they don't do that, then they're going to feel anxious that once again, they can't feel their body and they can't get it right and they're stupid. And so then they can't respond to those social cues and feel safe with their physical therapist. And then they no-show. You know, it makes a lot of sense.
So many times I've regressed my sessions just to be like, feel your butt, posterior pelvic tilt. And that was it. I spent the whole session doing that because the patient's body awareness was, I couldn't go any further. They had to learn what their butt felt like, what their hamstrings felt like, etc. So yeah, lately that's been very effective, and patients really do appreciate it when you just take the time. You said sometimes a whole session it takes just to feel these certain sensory points at their body, which is going to be very important for their home exercise program, down the line.
Yeah, one thing I've learned on that point, Brandon, I think that's actually an excellent point. But one thing I've learned on that point, just to give you guys a little bit of my experience, I've been in this for quite a long time, and I'm in home health, so I have like a degree of intimacy with my patients, which is great. But one thing that I usually do when I'm teaching that exact same strategy is to stay at the level of sensations. I think I maybe mentioned it before, but there's a tendency to go into like thought patterns and descriptions of the experience they're having. So they like start affiliating the experience they're having with like something concrete, which is like an idea or a story or a narrative or a thought pattern. And so they're like, oh, it feels like the chair, or it feels like my butt. So one of the cueing words that I usually give people now is just like, don't worry about telling me what it's like. Just try and stay as close to the experience you're having as possible. Be as intimate with it as you can. Just be deeply curious about it. And I find that that's actually really effective. And on to Nora's point, I wanted to comment on that, Nora. The polyvagal stuff is like really, really effective at kind of de-escalating people's energies. And it really does work well. That long exhale, I've noticed, is like very, very effective. In fact, I'm teaching nowadays, one of the first breathing exercises I usually teach people is like a 2-to-1 inhale to exhale, maybe with a short hold in the middle of it. But it's just about that like polyvagal stimulation, just kind of de-emphasizing or de-escalating that sort of fight or flight. It's miraculous, really, in practice. It's really a super quick and awesome tool. I love it.
Yeah, I think this is really connected to the polyvagal theory. I haven't necessarily seen them connected in journal articles, but it seems like it's all this one and the same to me. And going back to like the whole ergonomics and feeling your body type topic, that's one thing that Kelly Mahler's curriculum talks about too, is like, you're going to ask the kids, how do your hands feel? And they're all going to say, fine. They feel good. They feel normal. But yeah, we need to like really get more of that conscious awareness of exactly really being mindful of what the body part is sensing. And I know as a child growing up, like, and doing yoga, I grew up and went to Catholic schools. So they're like, pray. And, I'm just supposed to sit here and pray and think about things. And it was hard for me to be in a class. In high school, we had mindful Fridays, and we were just supposed to like meditate and pray for the whole time. And that was really hard for me. And looking back, it's like, that was probably a good thing to have, but I just didn't know how to do it. And same with when I've taken yoga classes before, it's like, I really have to focus myself on focusing on the body and not thinking about work.
Yeah, Kimberly's mindful yoga program is amazing for that kind of work. I highly recommend looking at her work.
Kimberly Carson.
Kimberly and Jim Carson. Jim spoke at our group. Was that? Gosh, it's been a while, like a year and a half ago or so.
Yeah.
Now, but yeah, Kimberly's mindful yoga stuff is just it's really beautiful and very, very immediately translatable into like daily practice with your clients and quite honestly with yourself.
And they just published a book. Let's see if I have it on my shelf somewhere. It's called Yoga Relief from Chronic Pain or something like that. Mm-hmm. Kimberly and Jim Carson.
The more experienced of a therapist I am, the less movements I have them do. The more sensation. It's turning into all sensory integration.
Nice.
It works so well. And the breathing, spot on.
There's just an article, I'm part of some Facebook groups, and one's called OT and Pain. And there was recently an article published, or it's in the works, about using the sensory profile with chronic low back patients. So I do think sensory processing and sensory assessment tools might be a new good thing for PTs and other providers to start using.
Nice. Well, great discussion. Any one last question or comment before we wrap up? I don't want to cut people off.
Will there be links to some of these resources that we discussed?
Yeah, I created a Google Drive
Oh.
with it, but I'll just maybe send those to, who's the one that made
Paul,
the website?
send it to Paul.
Yeah, and then he can add those to the website.
And,
Yeah,
and yeah, what I think will probably make sense is if there's a way that we can maybe do, I don't know, if we'll group it by presentation that has resources and the recorded talk, if we have a recording. I'm not sure how we'll set that up, but and if you have content that from presentations that you've already done, please send to Paul. If there's articles that you think would be helpful for people to read or resources, let's get that nicely bulked out so we can really use it and share it. You know, that's not, it's only open to people in the group, but the group is open to all, you know, all appropriate clinicians. So, and if you have other people you'd like to invite to this group, you can just go ahead and send the invite. And if they want to be on the list, let me know or let Paul know and we'll get them on the list. So great to see everybody. And Katie, thank you so much for a really, really well put together talk.
Yeah, thanks, Katie.
Thanks, Nora.
Of course,
Thanks, Laura.
more.
Nice work. Hey, Danny, can I see your little one before you sign off?
Dude,
No?
it's almost 9 o'clock, Nora. She goes to
Well,
bed
I
at
know, but you got a
6:30.
laptop. You can move it around.
Oh, yeah, yeah. Mhm, mhm.
That's all I get. Okay.
What
She's
do you
adorable.
want to see? I'll get you a better one here.
Oh, what a cutie. Look at those
She's-
toes.
She's so cute.
I bet. That's wonderful. Well,
Problem is
great.
she has my motor, which is like doing this. She never stops moving ever. Like she is a constant motor. It's insane. I'm gonna have to teach her how to lose graciously, purposefully, so other people can like have a chance.
Well, that's an important aspect of parenting.
It's
For
very
sure.
important to
Yeah.
understand your power.
Yes. Say hi to Petra.
I will. She's actually been checking you out. So she saw you, she smiled, she acknowledges you.
Excellent.
How often does this happen? Once a month?
Every 2 months.
2 months.
Yeah.
Perfect.
So I will be sending out I thought I sent them. I thought I sent them out for the year, but we'll attach some presentation topics to some of them upcoming. Yeah. So
It
yeah,
was really
glad
good.
it came.
You did a great job. Thanks so
Yeah.
much for letting me participate. I'll
Oh
see you in 2
yeah,
months.
absolutely. Okay. Bye.
Cool. Bye.